Okay, this month, as part of MEC Minute, we're going to talk about complications of pregnancy. Last month, we talked about routine vaginal deliveries that you might have to assist in if the mother is in active labor and has to deliver before you get to the hospital. This month, we're going to talk about complications of pregnancy that are associated with later pregnancy or associated with delivery. And these are things that you may see during the course of your career. Some of them can be real disasters for the mother and for the child. And for those, really what you need to have is a high index of suspicion. So we're going to talk about the complications of pregnancy, most of which are related to later pregnancy and the delivery. So why are we going to talk about this? Well, because pregnancy has risk for the mother and the baby. For most women, pregnancies are uncomplicated. A healthy baby is delivered either by cesarean section or vaginally, and everybody goes home happy. But sometimes things don't go as planned, and these can be medical disasters for the patients and can be very distressing for the family. For the parents and other family members. There is a wide racial variation in maternal death rates associated with pregnancy. So for white women across the country, according to CDC, there are about 11.7 deaths per 100,000 women. For black women, it's about 35.6 deaths per 100,000. And for all other races, non-black, non-white, death rate's around 17.6 deaths per 100,000 live births. Some of these differences can be due to the socioeconomics involved. Some can be related to genetics and ethnicity, but at this point there's no doubt that there's quite a discrepancy between white women and black women, and at this point I'm not able to really give you a great reason why, although I think socioeconomic has a lot to do with it, particularly in terms of access to good prenatal care. It's likely that you're going to care for one or more patients in your career who have a potentially life-threatening complication of pregnancy. And again, we're talking about later in the pregnancy. We're not talking about complications earlier in the pregnancy like ectopic. So we're talking about just this, for this talk, we're talking about complications related to the pregnancy. We're going to talk about probably about half a dozen or 8 different topics. We're going to talk about placenta previa. We're going to talk about placental abruption or abruptio placenta. We're going to talk about uterine rupture, which is unusual and rare, but you may see. We're going to talk about dystocia, which is the failure of pregnancy to progress. We're going to talk about malpresentation, meaning the wrong body parts presenting. We'll talk about cords wrapped around the neck. We'll talk a little bit about cord prolapse. And the last thing I want to talk about is eclampsia and preeclampsia, because this is probably the most common thing you're going to see out in the field. It's something you need to be aware of, something you need to aggressively treat, particularly for a patient who develops eclampsia. And we'll talk about that as the last topic. For treatment considerations, with pregnant patients, IV access is something to obtain. You never know if you're going to need it to give it medications or if the patient's going to need a fluid bolus. And if there's a complication or you anticipate a complication related to the pregnancy, high flow oxygen is important. Now, I know in months and years past, we've kind of played down the role of high flow oxygen, but if you're talking about a mother who was pregnant and in the late part of her pregnancy, if they're suffering a complication of pregnancy, then high flow oxygen is important. That's because patients who are pregnant develop a relative anemia, meaning they have less oxygen carrying capacity because their hemoglobin is diluted by extra fluid within the extra serum within the blood. So the ability to deliver oxygen to the baby can be impaired. So if there's a complication of pregnancy, such as a placental abruption, that little extra kick the baby can get out of that high flow oxygen being diffused into the blood is important. So if you're talking about a complication of pregnancy, high flow oxygen is important, and the best way you can give it is either through mask or a high flow cannula. All the things we're going to talk about place the baby and or the mother at risk of dying, particularly if they have a devastating condition and not rapidly transported to labor and delivery. And for most of our conditions, transport to the emergency department or to the, labor and delivery should be with the patient left lateral decubitus position, or like they teach with trauma, if the patient's on a backboard, tilt the backboard up toward the left. The reason we want them on their left lateral in a left lateral decubitus position is to get that big, heavy baby in the uterus off of the vena cava so there's improved venous return to the heart. Now, there's a couple conditions. Breech presentation is one, and prolapse of the cord is another, where the best position for the patient or for the mother may be in the knee chest position. We'll talk about that later. That can be a bit of dilemma if we're talking about, though, safely securing the mother to the gurney for transport. So you may have to make some clinical decisions in the field. The first of the conditions we're going to talk about is placenta previa. Placenta previa is where the placenta is completely or partially overlying the cervix. The cervix is the opening from the uterus to the vagina. So if the placenta is overlying that opening, it can cause bleeding. And during labor, if the patient goes into labor, that baby's head down on the placenta can cause placental separation, and these patients can bleed out very quickly. These patients typically have painless bright red bleeding. The bleeding can be heavy depending on the circumstances, and the bleeding can be heavy enough that you can lose the baby or the mother or both. It's well known in the world of obstetrics that if you know you have a placenta previa and the patient is in labor, you don't do a speculum or vaginal exam, because you're at risk of causing bleeding from the placenta previa, and the mother can bleed out before you get her on the cesarean table or on the operating room table for emergent cesarean. So always be aware of that in patients later pregnancy with painless vaginal bleeding, particularly if it's heavy. There are risk factors for placenta previa, which includes previous cesareans, previous placenta previas, cocaine use and abuse, multiple previous pregnancies in older age, and the only treatment for placenta previa is surgery or cesarean section. The one comment I failed to make earlier is placenta previa can occur commonly in early pregnancy, but usually as the baby grows, the placenta moves up the uterine wall, so it's no longer overlying the cervical os. The next topic is placental abruption or abruptio placenta. This is where the placenta separates from the uterine wall. It can be either complete, which is devastating because then there's no circulation in the child, or partial, and partial abruptions can heal. Generally, the patients have severe abdominal pain. If you palpate the uterus, it's hard. Most of the time when you palpate a uterus in a pregnant lady, it is firm, but it's not hard. Placental abruptions typically cause a rock hard uterus. The patient can have dark red, not bright red, but dark red vaginal bleeding. Sometimes, though, these abruptions can be asymptomatic, and literature suggests up to 20% of these cases can be asymptomatic, so the patient has no symptoms, and the abruption is picked up on ultrasound. Risk factors for placental abruption are similar to previa, although trauma is a greater cause of abruption and really has no relationship to placenta previa. But a patient who has trauma, particularly to the abdominal wall or to the trunk, can develop a placental abruption. So if you have a pregnant lady who's involved in an auto accident, particularly if they're in the second half of their pregnancy, they should be offered transport to labor and delivery so the baby can be checked out to make sure that there's no abruption or injury to the baby. Other risk factors include hypertension, multiple previous gestations or pregnancies, tobacco and cocaine use, and again, like placenta previa, treatment is via cesarean section. Uterine rupture is another thing that you may see in the field, although it usually happens at the hospital. Uterine rupture is where there's a rupture of the uterus and the baby either partially or totally is out into the abdominal cavity. Usually it's contractions and labor that result in the rupture, and if the baby is totally expulsed into the abdominal cavity, there's a very high fatality rate to the baby of 50 to 75%. Treatment is by cesarean section, and previous cesarean section is actually a risk factor for uterine rupture. Well, I took a look a little bit about dystocia and malpresentation. Dystocia is a fancy word meaning abnormal progression of labor. That can be due to either inadequate uterine contractions, so the uterus as a muscle just isn't squeezing enough. This is typically treated with Pitocin, which causes the contractions to be harder and firmer. There are sometimes fetal factors at play, such as a large baby. Labor can't progress because the baby is just too big. It could be something called shoulder dystocia, where the head is starting to present, but the shoulder, the top shoulder, gets caught behind the symphysis pubis and the baby just can't move. Or sometimes there can be congenital anomalies that just make the baby such that he or she can't be delivered through the vaginal canal. And then there are occasionally maternal factors such as a narrow pelvis or other structural abnormalities of the birth canal that prevent the baby from moving through the canal as you would expect. Malpresentation is the baby's in the wrong position, and it really means any body part other than the head looking backwards or looking down toward the rectal area. Any position other than that is considered malpresentation. So breech presentation is one, and then again, where any position where the head is coming down first, but the baby's just not in the usual position where the head is facing downwards. Just a word or two about shoulder dystocia, because you may see it if you get forced to have to deliver a delivery in the field. So in shoulder dystocia, as the baby comes down the birth canal, when the head first comes out, the baby's looking downwards, but then as the head comes out of the vaginal canal, the baby tends to spin, so one of the shoulders goes up. And when that happens, sometimes the shoulder gets pinned behind the symphysis pubis, and the baby just can't be delivered because it's stuck. This provides potential for complications besides not being able to get the baby delivered. Sometimes when there's shoulder dystocia, you can actually get traction on the brachial plexus, which is the bunch of nerves under your collarbone that go to your arm. So as part of shoulder dystocia, sometimes there's stress on that plexus, and you can have actually nerve injury to the arm. So there may be paralysis just due to the delivery process. So what do you do if you're faced with a case of shoulder dystocia? Well, there are some things you can do and some things that will be done in labor and delivery, but really some things are not within your scope. But the things you can do, one is the McRoberts maneuver, which is where mom's on her back and you have her flex her hips and pull her knees up toward her head. What that does is it kind of flattens the pelvis out enough so that the shoulder can drop down. The other thing you can do is, if you're trying to deliver the baby, have mom pull her legs back, but then also have one of your partners push down in the suprapubic area with a hand, and that helps often to push the shoulder out from behind the symphysis so it drops down into the birth canal and the baby can be delivered. If the baby's stuck in this position, then you're going to have to get the mom in the truck and get the mom to labor and delivery. There are some other maneuvers where the obstetrician can attempt to deliver one of the arms in order to get the shoulder out of the way, but that's, again, not something that I would expect you to do in the field. If you're looking at breech presentations, it's where the wrong part of the baby is presenting. It's usually the bottom part, and breech babies can be breached during the later parts of pregnancy, but usually the last weeks of the pregnancy they will spin around so they become head first. People talk about complete breech, footling breech, and frank breech. These are all different possible ways that the baby can present bottom first. So a complete breech is kind of like the baby sitting Indian style at the cervix, and that's how he's presenting. A footling breech is where one of the feet is going down first, and you may see the foot into the birth canal and then the buttocks, but the other foot is still wrapped up near the baby's head. And then a frank breech is where the buttocks is presenting and both legs are up by the baby's head. So those are just a point of information. I don't think anybody expects you to make this kind of a diagnosis in the field, although if you see a foot coming out, you have a pretty good idea it's a footling breech. So what do you do for these patients? The first thing you do is don't force the delivery. You can do a lot of damage by doing that. Another thing that you can do is, if the fetal parts are showing, support the body and allow the head to deliver naturally. That's an assuming that you simply can't stop the delivery. The delivery is taking place. If you have an idea to think, or if you think the mom is having a breech presentation, let's say, for instance, there's a footling breech with a foot coming out through the vagina, I doubt you're going to be able to deliver them in the field or even make an attempt, but you can slow things down by putting mom in the knee chest position. That's where she's on her hands and knees, her buttocks are way up in the air, and she puts her chest down on a pillow or down onto the gurney or bed. That way gravity helps pull the baby out of the birthing canal and hopefully slowing things down. Now my graphic shows a baby in a normal position, although maybe there's a prolapse cord, but what I really want you to get out of this diagram is the positioning. Now I know this also represents the dilemma for you in terms of patient transport. If you're going down the road to the hospital running emergently, is it really the safest position for mom to be in? Well, somehow you're going to have to achieve a balance, and I think that's a call you're going to need to make in the field. Other things you can do regarding treatment is IV access, and again, high flow oxygen in order to keep the baby oxygenated. So what do you do if the baby's in a breech position and delivery is imminent? Well, I've copied a section out of our protocol regarding breech presentations, and it talks about if delivery is imminent and inevitable. So you've tried putting mom in knee chest position, but things are just progressing. Well, there are two maneuvers that are talked about, and one of them is where you use a Pinard maneuver, where you use your hands to kind of sweep the legs down and out, so the legs come first and you can start getting the body delivered. And then while you're doing that, you get your hand under the baby's chest to support them so they're not falling out. The protocol also talks about the Marisope maneuver, which is where you and your partner work to get the baby's head out, and that's where you put one hand underneath the baby's thorax, using your fingers to support the neck, and some people even use one of the fingers to kind of put in the baby's mouth so you can pull the head down. Take your other hand, for me that would be my right hand, come up from the top, grasp the back of the neck, and gently push down and help get the head out. And then your assistant, your partner, puts some suprapubic pressure on the abdomen to help get the head out from behind the symphysis. These are very rare maneuvers. I'm talking to you about them because they're in the protocol. I've had very limited experience doing breech deliveries and hopefully don't have to do one, and I hope you're the same way. But I'm talking about this only because there's that really rare chance that you may be in a position of having to deliver a breech child in the field. Cord problems. Cord problems are common, particularly if we talk about cord around the neck. Typically the umbilical cord is free floating in the amniotic fluid, but sometimes it gets wrapped around the neck. And as the baby presents coming through the canal, the head is delivered, and then you see the cord wrapped around the neck. That cord needs to come off, and the way to do it is to gently put your fingers between the cord and the neck and unwrap it from around the head. Often when you do that, the delivery goes fairly quickly and you get the child delivered. If you don't get the cord unwrapped, the child may strangulate, or the cord may get pinched off, and blood flow to the baby is impaired. Sometimes you'll see a cord prolapse, so the cord is coming out through the vaginal canal, but there's no head, and often, but not always, often that suggests a malpresentation such as shoulder dystocia or a breech delivery, so be aware of that if you see the cord. What are you going to do for it? Well, you can put the mom in a knee chest position again. That puts the baby in a position where gravity helps pull the gravity out of the birthing canal and keep pressure off the cord. Keep the cord moist, so take a piece of gauze, moisten it with saline, and use that to keep the cord moist. And you can attempt to lifting the presenting part off of the cord, particularly if you palpate the cord and you don't feel a pulse. That is something you may just have to do. So when you see a prolapse cord, palpate it, check for a pulse. You should be able to feel it quite easily. If you don't feel a pulse, then you need to consider the various maneuvers that I talked about in order to get the presenting part of the baby off of the cord, and baby can then get blood flow back through the cord. Last thing I want to talk about is preeclampsia and eclampsia. So I think this is really the most common thing you're likely to encounter in the field. There's a caveat that I have attached to this, and I'm going to say it up front rather than wait till the end of the slide, and that is that eclampsia and preeclampsia can occur up to 30 days after delivery. So if you have a mother who delivered 2 weeks ago, you go on a run because she is unconscious or having a seizure, the first thing you should think about is eclampsia. That patient needs to be treated for the seizure and rapidly transported to the hospital. So what's preeclampsia? Preeclampsia occurs generally after the 2nd or 20th week of pregnancy. It usually involves edema and hypertension. As you may recall from medic school, pregnant women generally have a drop in their blood pressure as the pregnancy progresses. That's a physiologic response to the hormones of pregnancy and how the body's adapting to the pregnancy. Generally, pregnant women have a blood pressure lower than what their pre-pregnancy blood pressure was. But if you look at the blood pressure alone, a diagnosis of preeclampsia is based upon a systolic blood pressure of greater than 140, or a diastolic over 90, or a diastolic that's 15 points greater than what their pre-pregnancy blood pressure was. So if the patient has a routine blood pressure of 80 before pregnancy, and now you go evaluate her and her blood pressure is 110 diastolic, she's preeclamptic. There are also abnormal laboratory studies associated with preeclampsia. Generally, women have protein in their urine as associated with preeclampsia. If you do blood studies on them, they may have abnormal liver studies. They may have a low platelet count. They may have evidence of impaired renal function. Renal function is like blood pressure. Typically, the creatinine, which is a measure of renal function, drops during pregnancy. So if their creatinine is going up instead of down, that's consistent with preeclampsia as well. So what do you do if you have a patient who's preeclamptic? The treatment is transport to the hospital, put the patient in a left lateral decubitus position, again get that big heavy baby off of the inferior vena cava to improve blood flow from the lower extremities, and obtain IV access. And the reason I suggest you get IV access is because you never know when a preeclamptic patient may become eclamptic. So what's eclampsia? That's preeclampsia plus seizures. And those seizures can be life-threatening to the baby and to the mother. So what are we going to do if we have a patient who's pregnant in the second half of her pregnancy and now having seizures? And particularly if the patient has no history of seizures, we have to assume they're eclamptic. So we're going to stop the seizure with midazolam. We're going to put the patient on high flow oxygen. We're going to rapidly transport them, and we're going to treat them with magnesium sulfate. Magnesium sulfate is the drug of choice for eclampsia. It helps control seizures. It helps bring the blood pressure down. And we carry it in the truck. The dose is 4 grams in 100 cc's of saline infused over 20 minutes. That's a little bit different dosing than dosing for asthmatics. Asthmatics is 2 grams over 20 to 30 minutes. For eclampsia, it's 4 grams. Magnesium sulfate is generally a safe drug. The biggest complication of magnesium sulfate is if you give it too fast, the patient can develop respiratory depression and they may need some ventilatory support. But generally 4 grams over 20 minutes is a safe infusion rate. If you have a patient as eclamptic, they need to be rapidly transported. The hospital needs to be notified that you're coming, and then you go to labor and delivery where they can be stabilized and baby can be delivered as soon as possible. So eclampsia is a true obstetrical emergency. Your scene time should be short and the patient should be rapidly transported. That's all I have for now. I appreciate any feedback. You're welcome to send me comments via workplace or via email. I'll talk with you again next month.